Okay, so I'm going to go into a sort of a case presentation. I think it's probably the easiest thing to do at this point of the day because we're all a little bit tired. So this patient, this is kind of a little bit of a debate, and I think Dr. Moriali, who's my esteemed and respected colleague, will have his viewpoints on this, but I think that the MIS endoscopic technique can be very helpful, especially in certain circumstances. So this is a 34-year-old male who had undergone a previous L5-S1 discectomy for S1 radiculopathy by another person. I didn't do this. And then 3 years later, he came to my office and had a gradual onset of an L5 radiculopathy, so a different type of pain. So we got a selective nerve root block to confirm that the L5 root was the pain generator. He's very high-level individual, computer science engineering, PhD for a local company, 4 kids, exam, positive straight leg test, slightly weak EHL and numbness and gluteal pain. So this was his pre-op MRI prior to his first discectomy. Nothing too crazy, L5-S1 discectomy. He did well following this. And this is his pre-op 2018. Not a lot of big herniated discs, but what he has is this L5-S1 foraminal stenosis. And is the person here that brought up that hook L5 with the foot drop still here?
He left.
He left? Bummer.
That is exactly, he's my partner, that's exactly what it is.
This is what he's talking about, right? Yeah, so it's kind of strange that we're having this stuff. But so this patient is a tricky patient, because you've got this sort of three-dimensional foraminal stenotic issue that's occurring in this L5-S1 right-sided, otherwise normal facet, right? He doesn't have any back pain. He just has L5 nerve root pain. So how do people think they would attack this? I know this is a hard case on a Friday night, and there's a lot of stuff going on here, but.
I still like the A-lift. I mean, now that I know about this new phenomenon with the nerve. But I still, he does have, looks like some transitional anatomy, so I'd be a little cautious
Yep.
with the A-lift. I think it's supposed to be the best.
Yep.
But I would still go to it.
Would you do something before the A-lift because this nerve is really?
I probably wouldn't have had a CT, and I probably would have done a mini 360.
Okay, so you'd have done it open anyway because you wanted to get that.
Well, I would have done an A-lift
And then posteriorly done an open clean out, yeah.
and you went for MIS T-lift.
So how about just a unilateral T-lift?
Right,
Now that I know this.
right. Unilateral T-lift, you can go down. You can probably find that this hook is in the cephalad-caudad direction, right? It's not just a spike of bone. It's actually a wall of bone, right? This wall, right? That's cephalad-caudad. And it's actually kind of like obstructing the entire foramen.
Is that covered by annulus?
Nope, it's just a wall of bone. It's just like, if you imagine looking into the foramen, it's just a wall of bone that's just closing down on that foramen. Okay, so I elected to do an endoscopic decompression without a fusion, without any kind of instrumentation, bone grafting, anything like that. And so in this case, the disc height's pretty low, so I'm not going to get into the disc, right? That's not the purpose. I don't need to get into the disc. I need to work outside the disc. I need to work extradiscal and perform a really comprehensive foraminoplasty. Okay, so can you play that video?
Why is this a foraminoplasty and not a foraminotomy?
So plasty, in my mind, you're reshaping the foramen rather than just going in and kind of, it's a little nuance. And for me, I'll show you what I mean by the foraminoplasty.
This is a calcified annulus, correct?
Correct.
And if you looked at your fluoro, and obviously that's not weight bearing, it was a severely calcified, this was collapsed.
Mm-hmm. Go on, yeah.
So how is this much different than doing a posterior cervical foraminotomy in someone that has a spondylitic spine?
Because this is a little bit more lateral. So this is like it's like a subarticular stenotic issue at L5-S1 outside that foramen. So you could get out there with a curved, potentially get out there with a curved kerrison and work it from the inside out. I'm not going to say that's a bad thing. But then you're dealing with super scar tissue because he's already had previous surgery there.
I know, but I'm talking about recurrence. The pathology here is degeneration, progressive degeneration of that disc and calcification of the annulus.
Yeah.
That I'm sure you can take that spur out.
But it's not just the annulus. I'll show you what you'll see.
But it's the recurrence rate.
Uh-huh.
What do you do with the recurrence rate of something?
Well, yeah, if it does recur, which I'm hoping it doesn't, again, I'll show you why. But you do an ALIF. You fuse the guy. Okay, but he's 34, no back pain. Okay, go ahead and play. So we've already gone through this stuff. You don't need to see that. We're just going to kind of zip through it again. Okay, needle placement. I'm low. Now, this is the lateral aspect of the S1 joint. So that's what you dock on. My tube is docked on the lateral aspect of the L5-S1 foramen. The head is to the right and the feet are to the left. The L5 nerve root is at 5 o'clock, just to get you guys oriented. You can scoot it up a little bit for me. That's good, yeah, right about there. Okay, so now I'm just cleaning off. That's a bipolar. And I'm just kind of identifying the top and bottom. Scoot up a little bit more. No, you go back a little bit. You went too far. All right, so what I've done here is I'm going to take an articulating burr. So here's the articulating burr that I showed you before. And now I'm going to resect the lateral portion of this S1 facet in order to gain access into the foramen, because that's blocking me down. Again, the nerve roots, you start to see the nerve root down low around 5 o'clock. So now this is what the foraminoplasty concept is about. Okay, scoot up a little bit. That's good, yep. There's the burr again. Kind of like you get the whiteout effect because you've got a lot of bone dust. There's actually a joint, so you can actually point that up towards the posterior so that you're protecting. You know, you're not worried about doing anything there. The nerve is protected by the cannula, which is behind me. You can see it to the right. Okay, scoot up a little bit for me. Yeah, right there, that's good. Okay, now this is laser. This is what I was talking about before. If you use laser, really use a laser and know how to use it, it's an extremely powerful tool.
It's also disposable.
This is disposable with a tip, correct. Go a little bit further. Okay, so now you see that little hole there? Actually, back up just a tiny bit for me. Okay, good. So now you see the laser, what I'm doing is I'm removing the medial aspect of that S1. You see I'm thinning it out. And now what I'm starting to see is that white spike of bone. See it right there? That's our bad agent. So everything from midline to approximately 3 o'clock, it's got to go. The S1 root is right, or the L5 nerve root's right below me. So you start to see the root really clearly now. You'll see. Just hang in there, buddy. The root's right below you. You can start to see the root around 6 o'clock. Now I've rotated the cannula, so now I'm looking right. The root is around 6 o'clock now. See the root underneath me? That's the L5 root. You can see it pulsating. This is a side-firing laser.
So you're taking the bone down?
I'm taking that ledge of bone that's coming up from the annulus and circumferentially hitting that nerve. You see the spike? You see that white spike right there?
Right, but you also can't see what the laser is doing when it's doing it.
Well, it's a side-firing laser. So I know, and it has less than a 0.3 millimeter depth of penetration. So when you start to use the laser, you'll understand, you don't want to leave it sitting in one spot forever, obviously, right? You have to move it around. It's in and out, right? And so you're moving it in and out, and I'm removing that osteophyte.
So why not take a curette and go under it on the other side?
You can't, but the problem is you don't have a curette that's going to allow you to do that through. This is working through a 8 millimeter tube. And so you don't have the,
You can't use a kerosene.
you can use a kerosene. There are kerosenes that can go in there. But I didn't think I really needed it at this point.
And this is firing up toward into the set joint.
That's right. It's side firing. So now you're starting to see the root a little bit more.
You figure you'll get the other articular process prior to causing any other.
Yeah. And you can feel it. The patient's awake, he's talking to you. I'm talking to him about, how's the weather, what are you doing for this weekend, that kind of stuff. And he'll feel a little, when you use the laser, it's a little like that kind of thing. And you just tell him, oh, you're going to feel a little bit. It's resecting the bone right there. That's what it's doing. Up against the nerve, which is right below me.
They do this at the laser spinal?
No, they don't. The only thing they use the laser for is like they do this superficial dry rhizotomy. Okay, so there's the root below me.
They also burn the muscle tissue in a MIS disc.
And call it laser surgery. And that's why they're gone. Okay, so I'll speed it up just a little bit because I think this might be a little, go more than that. Yeah, that's good right there. This is a holmium YAG laser. Holmium YAG, yeah. You can go a little further. Okay, so now you see the root.
So we have a laser, and I've used it during discectomies to help take down things like this from the back and watching it.
Yeah.
It takes an extraordinarily long time for it to melt bone.
Yeah, you just have to understand what the settings are. So there's a double pulse setting and a single pulse setting. The double pulse is what you want to use. The first pulse basically evaporates the water in front of it. The second pulse is what does the bone. If you use a single pulse, it's going to take you about 700 years to do this. A double pulse at 60 hertz, you can go through that bone, just like you saw that little brown canal that I created there when I first did it. It takes about 3 seconds. And this is real time.
But you usually lead into the drill because is it safer or
A
more?
lot safer, and a lot more effective. And you can see the root right below me right there.
So how do you not damage the nerve?
Patient's awake, and I'm not touching the nerve with the laser from a laser perspective. It's just like a kerosene on a nerve. You would put a kerosene on top of that nerve in a heartbeat, right? You would go down, you put it outside that frame, and you take a bite, and you wouldn't be worried. It's the same idea. Remember, the laser is side firing. It's not going to touch the nerve. There are end cutting lasers, which you don't want to use in this case, obviously. And so now this is what I call the foraminoplasty. You see that ball? You see how it's shaped? And I'm done. That's the plasty part. You're actually reshaping the foramen, not just
Why are you done there, though?
because I took a ball tip probe. I went into the canal and palpated that, and I asked the patient, how's your leg pain? He says, I'm fine. So I've got the decompression and the patient telling me direct feedback.
He's under propofol, right?
No, not for this. He's awake.
So time out. So you have it prone,
Yeah.
and you ask him, is his leg actively hurting? And he says his leg's actively hurting.
No, he will at the beginning of the case. He'll say my leg is hurting. And then as you do the decompression, it becomes less painful for him. So I know that I've got the job done. And I take a ball tip probe, which does articulate, and I put it into the foramen and I palpate it.
Let's move on.
We got to move on.
Fantastic. All right.